بمنتصف الصدر، بأسفل الصدر، على رأس المعدة. Maybe the problem in the sphincters, the upper or in the lower sphincter. So we have to take deep history and we have to do more investigation to the patient. We have to take a deep history to the patient. So after taking the history, we can start the investigation as a laboratory or imaging study. Normal swelling, there are cortical, reflex, cortical, frontal cortex and brainstem, and there are cortical swallowing areas, swallowing center, motor nuclei, oropharyngeal and oropharynx and esophagus. So it's a system. There are balance between the system. Any abnormality in the balance lead to difficulty in swallowing. To our lecture, we have to concentrate in the problem that related to esophagus and how we can resolve or diagnose this problem and resolve this problem. In their esophageal motility disorder, the esophageal motility disorder classified to the upper esophageal body and lower esophagus, or maybe classified to primary disorder or secondary disorder. In the upper esophageal disorder, maybe due to upper esophageal disorder or neuromuscular disorder in the esophageal body, maybe due to achalasia, diffuse esophageal spasm, ventricular esophagus, non-specific esophageal motility, maybe due to achalasia or hypertensive lower esophageal sphincter, maybe due to primary disorder or secondary. So we will discuss in briefly the most common representation and treatable causes of dysphagia. The diagnostic. Any patient presented with dysphagia, we have to do a group of studies. Some physicians started with video fluoroscopy, some with barium esophagogram, some with esophageal manometry, and another with endoscopy. All investigation is important to reach the diagnosis. In esophageal manometry, there are a machine that detects the pressure in the esophagus during swallowing and resting, and it's classified the problem upon the pressure of the esophagus. We will not explain more and more about manometry. In the esophageal motility disorder, based on manometry, there are four classification: achalasia, which described as or definition is inadequate relaxation of lower esophageal, inadequate lower esophageal relaxation. In diffuse esophageal spasm, it's uncontrolled or uncoordinated contraction. In ventricular, it's hypercontraction. And in esophageal motility is hypocontraction. بيجيك المريض بيقول لك دكتور انا بحس اني باكل وبحس ان الاكل بيعلق على راسي. هاي بالحكي بتكون موست لايكلي ماشي مع كاليزيا. بالديفيوز اسوفاجيال سبازم بقول لك دكتور انا بحس انه الاكل بيعلق بصدري من ورا ومرات ما له علاقه بالاكل، بحس انه يعني صدري بشد وبرخي ما له علاقه بالاكل. لا تكرر اسوفاجيال سبازم بقول لك دكتور انا بحس انه صدري دائما شاد، المريء تاعي دائما منقبض، بضل قابض وشاد ساعه ساعتين ثلاث ما بروح. الاخير وهي يعني ضمنيا ضمن الحكي بتكون هايبو كونتراكشن، بقول لك دكتور انا بحس الاكل بيطول بالمريء لحد ما ينزل بس ما بيعلق، بس بحسه بيطول. In achalasia, the patient presented with delayed swallowing، بيكون الاكل معلق على راس المعده وبحس ان الاكل بعده المريء عنده. It's first clinically recognized esophageal motility disorder, described and treated well, and maybe 1 to 2% per 200,000 population usually present at age 25 to 60, equal in male and female, more than Caucasian, on the average symptom duration diagnosed 2 to 5 years. As we see in the picture behind, we see that this is a barium swallow, there are dilatation of esophagus, and there are bare beak or mild narrowing at the lower part of the esophagus. In the lower part of the esophagus, there are narrowing, and there are dilatation on the esophagus. As seen, this is the contrast. The white material is the contrast, and this is the barium swallow. It's an important picture to see and to remember. Degeneration. Pathophysiology may be due to generation of nitric oxide, producing inhibitory neuron, maybe due to loss of ganglionic cell in the myenteric plexus. Maybe that affects relaxation of lower esophagus, and maybe basal lower esophageal pressure. So this is maybe the most common causes that lead to achalasia or pathophysiology. يعني بتقول لك هي بالمختصر هي lower esophageal sphincter fails to approximately relax solely resistance to flow into the stomach, non-spastic of lower esophageal, but an increase in basal lower esophageal sphincter pressure often seen in 55 to 90%. And loss of peristalsis in distal two-thirds of esophagus. Clinical presentation solid dysphagia, then second postprandial regurgitation, chest pain, pyrosis, weight loss, nocturnal cut and recurrent aspiration. صحيح ممكن يجينا مرضى من الاكتليزيا بقول لك دكتور انا دائما معي التهاب بالصدري دائما بشكي من قحه فيها بلغم. So any persistent infection, chest infection, persistent cough, we have to think, and with the dysphagia we have to think with achilles. Then maybe we can order air fluid level in X-ray, wide mediastinum, absent gastric bubble, pulmonary infiltration with aspiration. Barium esophageal gland is most important. Maybe there are dilated esophagus with tapering of lower esophageal sphincter, bare weak appearance. This is a good screening test. And maybe we have to do endoscopy to rule out gastroesophageal junction tumor, especially in age more than 60. Esophageal myometry, absent peristalsis, decreased lower esophageal sphincter relaxation, and resting lower esophageal more than 45 millimeter mercury. This is in the picture on the left side. Picture A. This is an endoscopy with a patient who presented with food in his esophagus. This is the esophagus, and this is the esophagus, and this is the food. So the patient may present with presence of food and regurgitation and nocturnal cough. And the image in the image B presented the barium swallow. This is the white material contrast in the esophagus, and this is dilated esophagus, and there are bare beak appearance in the lower part of the esophagus and the intrasophageal. Manometric feature there are present complete relaxation, elevated resting pressure, and aperistaltic esophageal life. Treatment of achilles maybe there are a lot of techniques, but they are based on to decrease the esophageal pressure and increase emptying. We have to use the medication. Sometimes we use nitrate or calcium blocker, and we have sometimes use deuterium toxin. We have injection. We can inject the deuterium at the junction, so it's lead to relaxation, but it's need repetitive session. Also, we can use pneumatic dilatation. We use a balloon during endoscopy. We insert a balloon and inflate a balloon, not more than 300 Pascal. So it's lead to dilatation of sphincter. And there are surgical treatment which we use myotomy, laparoscopic myotomy or open. So in achalasia, we can diagnose it by one picture like this. If the patient presents with this picture, there are food in the esophagus, dilated esophagus, there are bare beak appearance, most likely with achalasia. Another spastic motor disorder of esophagus is diffuse esophageal spasm or nutcracker esophageal or hypertensive lower esophageal sphincter non-specific esophageal mutilation. Epidemiology, it may be at any age, mean 40 years, female is most important, more than male. Dysphagia to solid or liquid food, maybe chest pain, pyrosis symptoms. chest pain بيجيك مرة كثير بقول لك دكتور أنا رحت على طبيب قلب سويت قسطرة سويت ECG زرت أكثر من مرة طوارئ كلهم يقولوا لي ما فيش شيء so constant across the different disorder swelling is not necessarily impaired and can mimic cardiac chest pain. Another test we have, or the most important test we have to use, is a barium swallow. This is the picture presented in the patient with diffuse esophageal spasm. This is white is the contrast, and this is the esophagus, which is tortuous esophagus. This is most likely goes with diffuse esophageal spasm. Also, there are nutcracker esophagia or nutcracker esophagus. It's high pressure persistence contraction. The average pressure in 10 with swallowing is more than 180. 33 have longer duration contraction. May interconvert with diffuse esophageal spasm. So we have to know that there are hypertensive lower esophageal spasm or spasm, non-specific esophageal motility disorder. So there are differences between them. We will not go deep with this classification, you have to know the diagnosis from the picture like this or like this, and we will ask about the simple treatment for the achalasia, cerebral spasm, and sometimes for notochondrial esophageal. The diagnostic of spastic motility disorder of the esophagus, we have to do as previously, we have to do manometry, barium spectrogram, endoscopy, and pH monitoring. This is important. Spastic motility disorder of the esophagus treatment is reassurance, nitrates. We can give hydrolazine, calcium channel blocker. Also, we can psychotropic drug or dilatation. Hypermotility disorder may be its primary idiopathic aging procedures produce gradual decrease in contraction strength. Reflux patients have varying degree of hypermotility. All common patients with atypical reflux symptom usually resistance after reflux therapy, defined as low contraction wave pressure, incomplete peristalsis in 30% or of wet swallow. Hypermotility disorder may be due to secondary scleroderma, another disconnected disorder like CREST, diabetes, and other due hypothyroidism, alcoholism or amyloidosis. Then ischemic chest pain remains poorly understood. Functional chest pain. We have to do or psychiatric disorder or special disorder, maybe cardiac disease, and maybe musculoskeletal disorder. We have to do more and more investigation for any patient complaining of non-ischemic or chest pain, especially non-ischemic chest pain. Gastroesophageal reflux disease by far is the most common diagnosed esophageal cause. Maybe it's 5 to 60% have a heart pain and ascending regurgitation. 50% have abnormal esophageal pH study. Very low incidence of endoscopy finding. Maybe itis, maybe cysts, and most cost. A small subset of patients with non-GERD. The variety of esophageal motility disorder. Symptoms and motility finding correlate poorly. Esophageal hypersensitivity, hyperglycemia explains them. The reflux or gastroesophageal reflux disease, 36 to 57% from American experience. 50% have daily GERD symptoms. 14 to 20 have weekly symptoms. 15 to 50 have monthly symptoms. Symptoms include heart pain, acid regurgitation, water brush, dysphagia, atypical symptom, asthma, lupus, laryngitis, cough, bronchitis. Pathophysiology, slower esophageal sphincter dysfunction, relaxation, delayed gastric empty, esophageal dysmotility, plus minus hernia, repetitive mucosal injury, esophagitis, and Barrett's esophagitis. Lifestyle, we have to advise patient avoid caffeine, fatty food, smoking, lose weight, rise the head of bed, and eliminate light night meals. Also, acid suppression via BPI. Indication for surgery, failed medical treatment, need for lifelong medical treatment, hiatal hernia, atypical symptoms, complication like Barrett's or erosion. Preoperative evaluation, we have to do esophagogram, upper endoscopy, manometry, 24-hour esophageal pH monitoring. Surgical treatment is laparoscopic self-hand application. The goal of anti-reflux surgery is recreate angle of Hess, reconstitute laparoesophageal sphincter with wrapping. Predictor of good surgical outcome is typical symptoms, heart, regurgitation, abnormal pH score, and clinical response to acid suppression therapy. Other techniques for lower esophageal, that's a new technique and there is no proof to use it in worldwide because there are some complications and questionable about outcome. Hiatal hernia, it's presented most likely in patients who are complaining of epigastric pain and maybe associated with GERD. There are types of hiatal hernia, type 1, 2, 3, 4. Type 1 is a sliding hernia, type 2 is paraesophageal, type 3 is para and sliding component, type 4 other visceral involved. Clinical presentation post-prandial illness, maybe reflux, dysphagia, bleeding, vomiting, regurgitation, and dyspnea. This is the upper endoscopy report to the patient. This is the scope, black, and this is the stomach, and they are opening or weakness behind the scope. This is the hernia behind the scope, and the patient present with fullness, regurgitation, epigastric pain. Effective repair for hernia is excision of hernia sac, reduction of hernia content, repair for the crura, and further application to the patient. For upper esophageal motility disorder, we have to rule out many causes like stroke, Parkinson, polymyositis, multiple sclerosis, diabetes, myasthenia gravis, and dermatomyositis and polymyositis. And sometimes we have to do upper esophageal sphincter studies more and more and more for the patient, but it's complicated and it's poor understood. So we have to do more investigation like upper endoscopy, barium swallow, barium meal. We have to do manometry, pH manometry, and maybe, or there are a lot of or many differential diagnoses, maybe due to pharyngeal hypertension, pharyngeal atalasia, clinical manifestation like localized as upper cervical dysphagia. Within a second of swallow, coughing, choking, immediate regurgitation or nasal regurgitation. So we have to do a lot of investigation. It's complicated problem. Thank you. We finished the second lecture. We will take a break for 2 to 5 minutes, okay? Most common patient presented with epigastric pain زي ما حكينا سابقا بيجينا مرضى بيشكوا من وجع بطنهم بحكي له يعني وجع بطنك وين بحكي لك براس معدتي فبالتالي بنرجع للديفرنشال دايجنوستس الاول شو راس المعده الرايت ابر كوادرانت epigastric pain بكون معناته في multiple differential diagnoses maybe gastric ulcer maybe duodenal ulcer maybe gallbladder stone maybe biliary colic, maybe acute cystitis, maybe inferior MI, maybe lower lobe pneumonia. So it's wide differential diagnosis, wide. So we have to take deep and deep history, more and more information to reach the diagnosis. The peptic ulcer or duodenal ulcer is a common problem. Many patients presented with epigastric pain. After we perform blood investigation, most likely the investigation is normal, so we have to do the other steps or other step in the procedure to diagnose the problem. The peptic ulcer is a common problem in our population because of bad lifestyle habit and the presence of H. pylori infection. This image for patient or the stomach to the patient presented with severe epigastric pain, persistent vomiting. After we perform endoscopy, there are ulcer, lesion, and this is the pylorus. This is the small opening, the opening between the stomach and the duodenum. This is the pylorus, and this is the ulcer and the fungating region due to chronic infection. Ulcer, and there are a lot of inflammation in the other part of the body of the stomach. After the patient presented with severe epigastric pain, maybe this ulcer transformed to the ulcer or to the perforated ulcer or to the cancer like gastric adenocarcinoma or gastric lymphoma due to persistent infection of the stomach and the persistent ulcer and active ulcer in the body with the transformation of the tissue to the malignant tissue, like gastric adenocarcinoma. So acid peptic disease is classified as peptic ulcer, gastric ulcer, duodenal, hyperacidity, and Zillinger insult syndrome. It's maybe due to acute ulcer or stress ulcer or curling or Cushing ulcer. The incidence is 10% population affected. Gastric ulcer in elderly, 50 to 60 decades. Duodenal ulcer in 4th decade. And duodenal ulcer also in young age. Duodenal ulcer is proximal to the duodenum, most likely 1st and 2 centimeters of the pylorus due to increased acidity, and distal duodenum, most likely due to Zillinger insult syndrome. Image for patients presenting with severe epigastric pain. After we perform blood investigation, everything is normal. We perform upper endoscopy to the patient. This is the duodenum. In the image in the left side, there are 2 ulcers at the right and left, and this is classified as kissing ulcer due to the presence of severe duodenitis. Ulcer on the right, ulcer on the left may lead to stenosis of the duodenum, and this stenosis may lead to obstruction, recurrent vomiting, inability to swallow, and the patient presented with fluid electrolyte disorders. So we have to admit the patient, we have to do full blood investigation, stabilize the patient, stabilize in the, after giving, we give IV fluid, we give BBI, double dose proton pump inhibitor that decrease the inflammation and treat the causes of ulcer. And we have to do electrolyte managing, and we have to do surgical management if the medical is failed. The patient most likely presented with duodenal ulcer and gastric ulcer, they complain of severe epigastric pain, especially if there are perforation or bleeding or there are large ulcer in the duodenum. So we have to diagnose the problem as early as or as soon possible, and we have to take a biopsy from around the ulcer and from the stomach, randomized biopsy, and we have to do a study for H. pylori. We have to do a study for malignancy. We have to know the cause of the ulcer and severe inflammation of the stomach wall. Type 1 gastric ulcer is most common among gastric ulcer, proximal to the antrum. It leads because of decreased mucosal defenses and decreased acid. Type 2 is secondary due to the duodenal ulcer and pyloric stenosis. Type 3 it's pre-pyloric and pyloric canal ulcer due to increased acid and common etiology with duodenal ulcer. This image presented an ulcer in the fundal area. So we have to know that there are many sites of the ulcer in the fundus, in the body, pre-pyloric and duodenal. The management is same most likely, but we have to know the pathology, and we have to take a biopsy, and we have to do a follow-up endoscopy to rule out transformation to malignancy or to monitor the healing of the ulcer. Because we don't give the medication for 1 month only or for 15 days. Most likely we give antibiotic if there are H. pylori infection. We treat for 14 days antibiotic, then we have to repeat endoscopy after 4 or to 6 months to check the treatment, and we have to take daily tablets of PPI, and we have to stop smoking, stop coffee intake, also alcohol. We have to treat in the good lifestyle, eating in regular manner, and avoid spicy food, because this is a risk factor to increase a gastric ulcer or to perform gastric ulcer and increase gastric ulcer. In the image presented, we have to know that there are images presented with benign or malignant ulcer. As example, the benign ulcer, maybe it's small, sticking to the barium, according or accompanying the spasm, maybe it's due to decreased acid. The other may be malignant, which is large, maybe due to decrease also. Maybe large, attached to the stomach, perforation, fungating masses, a long amount of rouge of the stomach. In this image, this is the small ulcer, most likely benign. There are no invasion, there are no upper-going growth masses or invasion to the deep tissue. So we have to differentiate, most likely clinically, and the most important, we have to take biopsy to rule out the malignancy in the cancer on the ulcer of the stomach. The etiology, as we know, maybe the imbalance of acid pepsin and mucosal defense due to also H. pylori infection, NSAID, Zollinger-Ellison syndrome, type A personality. In H. pylori, 95% cause of duodenal ulcer and 80% of gastric ulcer. It leads to decrease in mucosal resistance, hydrophobicity, eradication, reduce the ulcer recurrence. That is the eradication, how we use the eradication. Many patients presented with duodenal ulcer. What is the eradication therapy? We have to give antibiotic. For 14 days, we have to concentrate on H. pylori treatment. We can give Flagy, Amoxicillin, clarithromycin, and the most important, we have to start with BPI, esomeprazole, lansoprazole, omeprazole as a double dose. After treating with antibiotic, we have to start also with BPI for 6 months, as we mentioned previously. Also, maybe due to presence of or taking a lot of NSAID medication, it leads to decreased acid secretion, increase in mucosal blood flow, prostaglandin, which lead to decreased acid secretion, increase in mucosal blood flow, and decrease in mucus pachyderm secretion. NSAID suppress this prostaglandin, which lead to increased risk of perforation and ulcer formation. It leads to 10 to 30% of chronic users of NSAID. In Zollinger-Ellison syndrome, it's recurrent, persistent, unusual site, multiple, and most likely malignant. So we have to know that there are another causes other than NSAID or gastric ulcer due to H. pylori infection or another cause of gastric. It's Zollinger-Ellison. There are type 1 and 2. Gastrin secretion from the non-beta cell of pancreas, maybe with gastrinoma, most common in pancreas, duodenum, antrum. 20% are multiple, 60%, 66% are malignant, and it's slow growing indolent tumor. Maybe or its parietal cell masses increased, genetic basis also we have to know, and massive hypersecretion of the acid in the study. In MIN1, there are hyperparathyroidism also presented with islet cell tumor and pituitary tumors. Also, maybe in the duodenal ulcer it's presented with due to NSAID, acid hypersecretion, rapid gastric emptying, impaired acid disposal, and smoking. So we have to know the causes, and we have to avoid the causes, and we have to treat the problem. In duodenal ulcer, there are also increased secretion of the acid, more rapid. Also in gastric ulcer, there are also causes H. pylori, NSAID, duodeноgastric reflux, and impaired gastric mucosal defenses. So the problem in general is similar, and we can treat in the same manner of the treatment, but we have to know the proper cause, and we have to treat the gastric and duodenal ulcer and to rule out malignancy or another causes of ulcer. Duodenal ulcer in common presentation, clinical presentation, duodenal ulcer, pain relief by food or alkaline, and pain several hours after meal. In gastric ulcer, the pain comes usually after eating or on eating. يعني كثير من المرضى بيقول لك يا دكتور انا بكون عندي الم لما اكل بزيد، وكمان لما يقعد بعد 3-4 ساعات بزيد. تلاقي المريض بالاغلب عنده duodenal ulcer وجاستريك ulcer، يعني مزدوجات مع بعض. بالانفستيجيشن قد ما سويت بالduodenal ulcer والجاستريك ulcer، اذا سويت CBC وكدني فانكشن ليفر most likely they appear normal most likely. مرات بيكون في عندنا increase white cell count، مرات بيكون عندنا drop بالهيموجلوبين due to bleeding، بس most likely we have to do endoscopy because the sensitivity is 90%. But in all patients with severe pain, to exclude biopsy can be taken and to test for H. pylori. The barium meal, double contrast, the sensitivity also 90%, but take more time and maybe consume more and more time for preparation imaging study. So I prefer, or the guidelines prefer to do endoscopy. To rule out H. pylori detection and treatment, we can use a breath test, blood test, and tissue test. We prefer also stool antigen to detect the H. pylori, and the breath test to rule out treatment of H. pylori. Also in differential diagnosis, this is most important. Most common patient presented with epigastric pain, we have to rule out cholecystitis, as we mentioned previously, hiatal hernia, pancreatitis, MI, pneumonia, dissecting aneurysm, or Wallen's tumor. The treatment is most important, as we mentioned previously. We have to stop smoking, and we have to stop taking NSAID and change medication. We have to stop alcohol. We have to take antacids. Antacid, there are many medications. We prefer to use BBI, not H. pylori, as BBI is a proton pump inhibitor like omeprazole, esomeprazole, pantoprazole, omeprazole, rameprazole. Any medication that are related to this family, you have to give patient medication. Also, we have another medication as a saccharate or bismuth. This is used previously, and we can use now. Also, we have to use the antibiotic. The regimen which we use is amoxicillin with clarithromycin and or plus minus metronidazole and BBI, omeprazole, or rabeprazole. Previous medications, which is H2 blocker, it's not like BBI and H2 blocker. We do not prefer to use now. It works in parietal cell, and we can take this medication in daily life for mild gastritis or in pregnancy, in a pregnant woman. Duodenal ulcer, 90% controlled by medical treatment. If there are indications for surgery, it's indication for complication, not the ulcer itself, complications as a bleeding, perforation. And as we mentioned previously, we have to use any medication from omeprazole because it's better than ranitidine or H2 blocker. Ulcer heals in 6 or 90% by 6 months, and recurrence decrease 95% by H. pylori eradication by using the medication, the antibiotic. Indication for surgery, as we mentioned, for hemorrhage, obstruction, perforation, and intractability of the vein. The management is dependent on the patient, physician status, patient status, and physician manage to treat the ulcer and duodenitis. Indication, as we mentioned, for hemorrhage, bleeding more than 6 units, or recurrent bleeding after endoscopic control. As we mentioned, we can insert or do endoscopy, reach the duodenum. If there are bleeding, we can stop it by ligation, by clipping, by injection of epinephrine in the mid-duodenum. If there are failed treatment by endoscopy from the first or second time, sometimes we can do surgery. And also we have to do a resection of the duodenum first and second, but first part most likely because of the second part there are ambulatory and the complication is more and more toward the sometimes do major surgery like open surgery, so we have to avoid and resect the or treat the hemorrhage, and we have to do an anastomosis with gastric anastomosis jejunum, or there are maybe gastrojejunostomy, a birth 1 or birth 2 surgery. We will not mention here. Definitive surgery for duodenal ulcer before they treat, before the use of omeprazole, they are previously used high selective vacuotomy or total vacuotomy with pyeloplasty. But till now we do not use. For perforation, we can use a Graham patch. And we insert a omentum in the perforation, and we take a stitch or we fixate the omentum in the perforation area. So we close the perforation and we give double dose BBI or BBI as a continuous dose of treatment. For treatment of ulcer, we can do distal gastrectomy if there are perforation, and gastroduodenostomy or gastrojejunostomy. For proximal ulcer, we have to use total gastrectomy, and this is a major surgery for gastric ulcer, and we have more complication award this surgery in the acute cases. The death is increased with time if there are hemorrhage or erosion ulcer due to erosion gastroduodenal artery. As we mentioned previously, we can treat by laser or injection or clipping. Perforation in 5 to 10%, pneumoperitoneum present in the imaging study. We have to rule out differential diagnosis of acute appendicitis or perforated enteric perforation of the bowel. So we have to do CT scan to rule out perforation. If there are perforation, we have to treat, as we mentioned previously, and we insert a Graham patch on the perforation. Obstruction may be due to, as we mentioned previously, and due to kissing ulcer in the duodenum, kissing ulcer and the ulcer closed completely the duodenum, which lead to persistent vomiting and a lot of complication. It leads to fluid imbalance, electrolyte imbalance. So we have to know the cause of the problem. Where in the obstruction we have to do endoscopy, barium study, also barium meal, and this treatment of vagotomy, gastrojejunostomy or gastroduodenostomy. Thank you. Thank you. هذا عنده استفسار؟ The next lecture today is benign anorectal disorder. The anatomy of rectum and the anus, as we see that there are origin of the rectum from the level of the third sacral vertebra. It descends along the curvature of the sacrum and coccyx and ends at the passing through the levator ani muscle. The rectum differs from the colon in that the outer layer is entirely longitudinal muscle, characterized by merging of the 3 tinea bands. It measures 12 to 15 centimeters in length, and it lacks mesentery, and the lacks the mesentery, scoriations, and the appendicular epiphyseal. The rectum describes 3 lateral curves. The upper and lower curve are convex to the right, and the middle is convex to the left. On the inner aspect, this enfolding into the lumen are known as the valve of Houston. زي ما احنا شايفين بالصورة هون في عنا الفالف الأول على الرايت، الفالف الثاني على الرايت، والفالف الثاني على الليفت. Why we give this? Because when we do endoscopy, we have to know the good anatomy to do endoscopy, to avoid perforation, to do a good endoscopy, to see the pathology harbor in the rectum. Because the treatment of the rectal cancer is different than colon cancer, and we have to know the region upon the site of the mass. In the rectum, it's closed area, sensitive area. There are posteriorly, there are sacral area, and anteriorly there are vagina, and there are in female, there are urethra, and there are urinary bladder. Also, it's a complicated area and closed area. And the complication of this area, especially in fistula abscess, is complicated process if it is high complication or high fistula. As we see, there are external anal sphincter, internal anal sphincter that around the anal verge. There are anal verge and external anodeme and internal anodeme. And there are many complications happening in this area. This area is a sensitive area, as we mentioned previously, and it's harbor many benign and malignant cause of pathologies. Maybe some patients present with bleeding per rectum, masses, pain. So we have to do good investigation, good examination to reach the good diagnosis to make the good treatment. As we know, the normal anatomy of the canal, there are anal canal also, it's about 4 centimeter long, terminate at the anal verge. Posterior to the anal canal is related to surrounding muscle and coccyx. Laterally is squamous canal, squamous fossa, and anteriorly there are urethra and there are vagina and posterior vaginal wall. The lining of the anal canal, consists of epithelium of different type at different level. The dentate line, this line is approximately 2 centimeters from the anal verge. Elliptical folds or column of Morgagni, of which were 6 to 14 are known as column of Morgagni. This is a small pocket of crypts at the lower end of the folds. Other crypts are all important in the controlling the anal tunes, nectar, gases, passage. The crypts are of surgical significant because of risk of obstruction, which lead to more problem and resulting in sepsis. يعني زي ما بنحكي احنا بالعربي، خلينا نحكي اول مشكله بتواجه المريض بقول لك دكتور انا معي بواسير hemorrhoids. Hemorrhoids are not varices or not varicose vein. Are not and not everyone has a hemorrhoid. Everybody has an anal Cushing. A Cushing اللي هم longitudinal lines that present in the longitudinal folds that present in the anal canal. So dilated Cushing is the hemorrhoid. The anal Cushings are composed of blood vessels, smooth muscles, and elastic connective tissue. They are located in the upper anal canal from the nectar line to the anorectal ring. 3 Cushings line with the following constants: the left lateral and right, and the right anterior lateral and right posterior lateral. The etiology is most likely the hemorrhoid presented as a cause of chronic constipation, which has been considered the cause of hemorrhoid. Other studies shows that the patients with hemorrhoid are not necessarily constipated, but tend to have abnormal anal pressure. So you have to take a deep history to know that this patient complains of constipation or not. If he does not complain of constipation, you have to rule out abnormal anal pressure. Many patients presented in pregnancy due to hormonal changes or portal hypertension. So we have to take a deep history to rule out portal hypertension, liver cirrhosis. Because any surgery to the patient with hemorrhoid, it's lead to massive bleeding, especially if the patient is in portal hypertension. Also in pregnancy, we can change the lifestyle and give medication to the pregnant. And after pregnancy, after delivery, we can give medication or do surgery to the patient. Clinical presentation of piles most likely present with a bleeding, mucosal prolapse, and chronic status may be prolapsed with prolapsing of the mucosa outside with fecal leakage, resulting in pruritus and excoriation of perineal skin. Pain may be presented with pain, especially if it's external hemorrhoid, prolapsing or strangulation hemorrhoid present as acute problem with the symptoms of pain associated with discharging edema, tender, reducible hemorrhoid, gangrene infection with sloughing, and secondary bleeding. Before we treat piles and hemorrhoid, we have to ask the patient or to advise the patient about the diet and debulking agent. So there are also treatment in the clinic like a rubber band ligation, infrared photocoagulation. Also we have another treatment like electrocoagulation, sclerotherapy, and cryotherapy. So the treatment is lifestyle. We have to avoid constipation. You have to advise patients to eat diet, drinking water, walking more and more, avoid constipation. Then we can do surgery. But before surgery, we have to give also medication to relax the anal sphincter, like nitroglycerin lotion or nifedipine, also to give painkiller like lidocaine gel, also to give some medication to decrease blood supply to hemorrhoid, which lead to decrease in size. Some patients or some physicians have to treat patients with partial lateral sphincterotomy because the theory that constipation maybe is not the cause, as we mentioned previously, and the increased inner sphincter is the cause of this problem. This is the common presentation. This patient presented most likely to the students, the doctor in the clinic. This is the external hemorrhoid, thrombosed strangulated hemorrhoid. The treatment is to do resection. Before that, we have to give a painkiller, to give IV fluid to stabilize patient. If he is in severe pain, then we can admit patient to the surgery to resect the thrombosed bite. Fissure, the second pathology, is fissure is a painful linear ulcer. Is situated in the anal canal and extended from adjacent below the dentate line to the margin of anus. In the acute phase, the region is often flat in the epithelium cells, but cause much more pain and spasm. Affect both sexes equally. Posterior fissure in 73% is the most common fissure. The vessel passing through the sphincter muscle are subjected to contusion during period of increased sphincter tone, and that the resulting decrease in the blood supply, which may lead to pathogenetically relevant ischemia at the posterior commissure. The fissure, there are acute fissure and chronic fissure. The aim of treatment of acute fissure is, in the end, is to break the cycle of hard stool, pain, and reflux mechanism. So we have to give any debulking agent for the stool, give a painkiller, and give a nitroglycerin lotion to decrease the sphincter in the anal tone. The most important is to ask the patient to lifestyle and avoid constipation. Surgery for fissure is dilatation, lateral sphincterotomy, open or closed technique. So this is an important chart. We treat a fissure by cutting the cycle of pain, of constipation, and fear of passing motion. And by cutting any cycle of the pain and reflux spasm or hard stool, the problem will resolve gradually. If there are no treatment to this pain or constipation, the problem will present most likely to the patient or reoccur to the patient. The third pathology is the anal fistula, is an opening between perineal skin and the cavity of the anal canal or rectum. According to the site of their internal opening, they can be classified into low fistula, high fistula. So the treatment for low fistula is different. The high fistula, low fistula is simple, no complication most likely. There are no problem when we treat in patient with low fistula. As for high fistula, the internal opening may be in the anal canal or above the anorectal ring. For fistula, we can classify it as a submucosal, intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. This classification is important because the treatment is different upon the cause of fistula, upon the classification of fistula, because the submucosal treatment is simple, easier than extrasphincteric or suprasphincteric or transsphincteric. This is a good rule that classifies the fistula upon the anterior fistula or posterior fistula. The posterior fistula most likely is direct forward. The anterior fistula, the posterior fistula most likely as a curve, deep, and it needs more and more management because it contains a lot of tissue inside. This is an imaging technique. It's called an endoscopic ultrasound. We diagnose the pathology using endoscopy, as there are fistula or abscess, by identifying the localization of pus or fistula tract by ultrasound. It's important. We can use it safely in the clinic, and we can classify the fistula upon the ultrasound or MRI. Also, this is another endoscopic ultrasound. We can see in this endoscopic ultrasound, this is an image. There are internal anal sphincter, external anal sphincter. There are abscess area. In the previous image, it's an abscess in the arrow below at 7 o'clock. And this is the normal anatomy for endoanal endorectal ultrasound. The principal fistula treatment is fistulotomy or fistulectomy, and sometimes we can use a flap upon the type of fistula. This is a technique that used to insert for high fistula that containing much muscles inside, or mucosa, much mucosa and muscles, which if we open the fistula may lead to incontinence. So we have to insert the ceton and to avoid complication. This is an area for a fistula. It's in the left side of the image or right buttock. There are opening far away from the anal canal. This is a high fistula, long fistula. We have to treat it gradually and we cannot open. We have to insert a hydrogen peroxide, a material that detects that there are opening internal with the anal canal. Then we can open the tissue and we insert a ceton which is inserted through the fistula, and we put it for many times, 1 month, 6 weeks. Then we do another surgery. So the treatment of fistula sometimes is complicated, especially if it is high fistula or long tract fistula like this. Sinus, spinoneedle sinus, is an spinoneedling hair, nidus meaning nest, to describe the chronic sinus containing hair and found between most likely the buttocks. PNS is a chronic subcutaneous abscess in the natal cleft which spontaneously draws through the opening. The acquired theory is now widely accepted. The affected hair follicle becomes stented with keratin and subsequent infection, leading to folliculitis and formation of abscess that extended down to the subcutaneous fat. The treatment, an operative treatment, most likely lateral incision and excision of midline bits or wide local excision. This is the PNS in the natal cleft. Most likely it's presented with pain, discharge, so we have to do excision in this case. Rectal prolapse is the protrusion, the other pathology is the protrusion of the few or all layer of rectal mucosa membrane through the anus. Prolapse of the rectum may involve only the mucosa, or it may involve all the layer of the rectum protruding the anal canal. Most cases of childhood prolapse occur in young patients younger than 4 years, equal in both sexes. Pediatric rectal prolapse is more common in the typical tropical and underdeveloped countries where diarrhea and parasite infection play much greater roles. Maybe due to increase in intra-abdominal pressure, parasitic, neoplastic, malnutrition, cystic fibrosis, ulcerative colitis, Ehlers-Danlos syndrome, rectal neoplasm previously repaired in a rectal angle. The condition which increase intra-abdominal pressure may be constipation, diarrhea, BPH, chronic obstructive pulmonary disease, cystic fibrosis, cystomyosis, Wood-Equine syndrome, spinal tumor. This is the common presentation of prolapse. The patient, all the rectum, all the urine come through the anus canal, and this is emergency, especially if it's delayed. Patient present with sepsis, decrease blood, decrease or hypotension. So we have to treat this as stabilize the patient. Then we have to do surgery, or there are multiple surgeries to the patient. Previous techniques that used to insert delirum, mucosal sleeve resection, or maybe Altemer, or maybe surgical or resection for rectum and sigmoid, and the outcome of the procedure is questionable, and maybe the patient most likely complain of rectal pain, feeling of complete evacuation, or recurrent prolapse. Another pathology for inner area is anorectal abscess. It's infection originating in sphincteric space, most likely in all inner canal. بيجيك المريض بيقول لك دكتور عندي وجع في منطقة الشرج. تفحصه ولا في عنده انتفاخ، حرارة، ألم، most likely ماشي مع abscess. بس تفتح الابسس بتحكي للمريض 50% الابسس اللي فتحنا لك إياها، الدمل اللي عندك ممكن هاي 50% من الدمام اللي فتحناها تتحول وتصير إلى فيستولا كما في الصورة. هاي الفيستولاس كلياتهم ممكن يكونوا سابقين لابسسز فتحناهم وصاروا فيستولا، لانه الابسس موست لايكلي 50% تتحول لفيستولا. فبالتالي تحكي للمريض انه هاي التندرنس اللي عندك والهوتنس كلياتهم في عندك دمل عمل بدي افتح لك اياهم، لكن ممكن 50% تتحول وتصير عندك فيستولا. Most likely it's due to E. coli bacteria implication, Enterococcus bacteroides. It's due to infection of cryptoglandular epithelium resulting from obstruction of the gland. Other causes may be Crohn's, TB, carcinoma, trauma, inflammatory pelvic condition like appendicitis. So So there are glandular secretion stasis, infection separation, abscess formation, anal crypts obstruction. Clinical presentation, most likely it's perineal pain, or ischiorectal, or intersphincteric, or supralevator. So the site of the abscess presents in different way. The ischiorectal chills may be fever, ischiorectal pain. In intersphincteric may be rectal pain, chills, fever. In supralevator may be PR tender, difficult to identify. So endoscopic ultrasound are needed. So we give or to open the abscess, and sometimes you have to give antibiotics to the patient presented with abscess in immunocompromised or DM patient. We open in cruciate technique, and it's opening and ask the patient to do regular bathing and dressing after the open the abscess. Thank you. حمزة موجود؟ حمزة هنا؟ دقيقة ورح نعطيكم محاضرة الأوبستراكتيف جوندس، بس زميلكم حمزة يخلص الإجراء على التيمز وهين نشتغل عليه إن شاء الله. يعطيكم العافية. The last lecture today is about jaundice. As we mentioned previously, we see that there are gallbladder, liver, and common bile duct. As we are in this course, we will concentrate only the surgical cause of jaundice, not medical cause of jaundice. Some patient presented with gallstone. As we mentioned previously, maybe gallbladder stone, acute cholecystitis. If there are slippage of the stone in the common bile duct, the patient presented with jaundice. The complexity of the biliary tree can be broken down into much simpler segments. The intrahepatic duct converges to form the right and left hepatic duct, which exit the liver and join to become the common hepatic duct. The cystic duct branches off the common hepatic duct and drain the common bile duct. The common hepatic duct continues toward the duodenum, but it is called the common bile duct after the takeoff the cystic duct. The common bile duct then joins the pancreatic duct posterior to drain into the second portion of the duodenum. Obstruction, inflammation, or infection of the biliary tract change the baseline anatomy and size of various ducts. The normal caliber of the common bile duct and pancreatic duct are less than 8 mm and 4 mm respectively. The gallbladder typically, the gallbladder wall is typically less than 4 mm. Jaundice is the yellowish or the yellowing of the skin and is clear due to abnormality elevated level of bilirubin in the blood. It can be characterized into 3 different categories, including prehepatic, intrahepatic, or posthepatic. The pre and intra cause are known as a medical jaundice, while post-hepatic or obstructive jaundice is considered a surgical jaundice, which we will concentrate here. In the pre-hepatic jaundice, there are excessive production of bilirubin with ability of the liver to conjugate the bilirubin and excrete in the gut. This is a predominantly unconjugated hyperbilirubinemia. The most common cause of pre-hepatic jaundice is hemolytic anemia, which causes excess heme breakdown. In intrahepatic causes are due to parenchymal liver disease with the inability to either conjugate or excrete bilirubin. In this case, the fraction of bilirubin that is elevated varies. Viral hepatitis often has a predominant unconjugated hyperbilirubinemia. A conjugated hyperbilirubinemia is seen with cholestasis from drug or primarily biliary cholangitis. In the post-hepatic, which is the main topic in this lecture, in post-hepatic jaundice or obstructive jaundice, there is an independent flow of bile duct to complete obstruction of hepatic biliary passage in the liver and the duodenum. Obstruction can occur within the biliary duct themselves or more distal within the pancreas. This is a predominantly conjugated hyperbilirubinemia. Surgical jaundice is suspected over a medical jaundice in the following scenarios: a history of abdominal pain and fever, venous jaundice with weight loss, pruritus, clear color stool, conjugated hyperbilirubinemia with elevated alkaline phosphatase gamma GT. An elevated gallbladder, abdominal masses, and or lymph node in the left supraclavicular area is considered advanced disease. Distinguishing surgical jaundice from medical jaundice is that the first step in diagnosis and treatment. Post-hepatic obstruction can be located in several different areas of the biliary tree and can be due to a variety of benign and malignant pathology outlined below. Due to benign causes, cholelithiasis, Malaysia syndrome, bile duct stricture, chronic pancreatitis, primary sclerosing cholangitis, and cloacal cysts. In malignant causes may be pancreatic, solid, cysts, cholangiocarcinoma, Epstein Barr tumor, pediatric due to biliary atresia, and any iatrogenic may be common bile duct injury. Following laparoscopic cholecystectomy, also there may be an ischemic stricture from cautery or hepatic artery injury. So we have the distinguishing the cause of jaundice, pre, intra, post-hepatic by taking a full history, a do-good exam, and investigation. Risk factors for gallstone and possible cholelithiasis are important to obtain. This includes obesity, female gender, age more than 40. Prior intra-abdominal pathology should be identified, including a history of inflammatory bowel disease, which can have associated with hepatic steatosis, cholelithiasis, or primary sclerosing cholangitis, زي ما ذكرنا في محاضرة الجولستون. A history of pancreatitis should be noted as this can lead to biliary stricture. Any iatrogenic interventions such as surgery, endoscopic are critical to obtain. On physical examination, we have to focus exam and we have to help narrow the possible cause of jaundice. This should include a general abdominal and rectal exam. Overall general exam allows the clinician or clinical to determine the severity of illness and the urgency of intervention and level of care required. Also noted in general exam is jaundice itself. This is defined as yellowing of the skin and whites of the eye that accompanying high level of bilirubin and is typically seen when the level are greater than 2 to 3 milligrams per deciliter. Bubble gallbladder mass in the abdomen or lymph node in the supraclavicular, the virtuous node are suggestive of malignancy causing obstructive jaundice. Stigmata of liver failure or portal hypertension such as capitomidosis, pyelon nevi, and ascites are suggestive of chronic parenchymal liver disease and an intrahepatic cause of jaundice. As we mentioned previously, the Charcot triad and Royde-Montad to rule out inflammatory process of obstructive jaundice and severity of case. And we also explain the signs on ultrasound and examination. And in the examination, maybe there are sclera icterus, capitomidosa, and rectal varices in presence with cirrhosis of the patient. In laboratory test, we have to order the complete blood count, liver function test, kidney function test, to rule out an inflammatory process as if there are leukocytes, maybe infection. If there are stone or sludge in common bile duct, they are elevated in total and direct, especially direct hyperbilirubinemia. In imaging study, also we have to do ultrasound, gallbladder and biliary system, cholangiopancreatography. Also we have to do MRCP, ERCP, PTC, and contrast percutaneous cholangiography. And sometimes we have to do endoscopic ultrasound or contrast enhanced CT abdomen. This is an ultrasound for patient presented with upper epigastric pain. There are inflamed large gallbladder and there are presence of stone and shadowing of the stone in the ultrasound. And this is ERCP, where there are insertion of the probe and there are a wire here inserting the common bile duct. And this imaging test we can there are obstruction, dilatation common bile duct, presence of stone or sludge, and we can do also balloon, angioballoon or sphincterotomy through the ERCP. Also we can use ERCP or percutaneous cholangiography, and we see the biliary tree inside the liver, and there are obstruction or stone or sludge. So the treatment and management of obstructive jaundice is to based on the accuracy of the disease and clinical status of the patient. Patient with hemodynamically unstable coagulopathy and renal dysfunction need to quickly resuscitate prior to management with specific etiology of obstruction. So we have to give IV fluid, we give IV antibiotic, we have to give BBI, we have to take a blood culture, Arabic and anaerobic. Then we can start with ERCP, MRCP, and the treatment of or to relieve the obstruction. So we have to do resuscitation to the patient. The patient present with bronchitis, we have to give intravenous fluid, broad-spectrum antibiotic, and if there are coagulopathy, we have to correct coagulopathy, and further in treatment after stabilization. Also, we can perform ultrasound to rule out and blood culture to rule out an sepsis, or if the patient presented with sepsis or septic shock, we have to do stabilization that we can't do. So the major point we have to know that the type of imaging we treat for obstructive jaundice, the jaundice for surgical cause is most likely due to obstruction of common bile duct or in the hepatic duct. We have to treat and we have to diagnose. Upon the treatment, we have to use ultrasound, MRCP, ERCP. Before treating the cause, we have to do stabilization to the patient, because stabilization is the crucial step, and we can stabilize the patient 2 to 3 days after stabilization. We can start doing the surgery or ERCP, which elevate or we give us a good description for the pathology and the treatment for the pathology. Thank you. هيك انتهت محاضراتنا اليوم. نشوف زملائكم شو عندهم اليوم. سيمينارين إن شاء الله. تفضلوا بالسيمينار الأول. طلاب
اعطيتهم اونرز، بس لازم من عندك تسوي لهم يعني انه ادميشن يفوتوا.
وين موجودين حمزة؟
موجودين حسام واسلام كأنه.
انت حطيتهم اونر لانه مش مبين عندي انا.
لا محطوطين.
خليني اشوف. خليني احكي معك تليفون.
يلا ماشي دكتور ماشي.
Definition: laparoscopic, laparo meaning flank, side, and scopy to see, is an operation performed in the abdomen or pelvic through small incision with the aid of camera. أول ما تسمع laparoscopic لازم تعرف إنه هاي العملية بتصير بالبريتونيوم كافيتي، يعني بالبلفيك والابدومين. لازم تفرق عن باقي العمليات الثوراكوسكوبي إلى آخره. تمام. Minimum invasive surgery diagnostic procedure usually to examine the organ inside abdomen that require only small incision. اللاباروسكوبي ممكن يستخدموها كتريتمنت. الشغله الثانيه اللي بيستخدموه فيها كديagnosis، مثلا في حاله الاكس راي والسي تي والالترا ساوند ما بين معنا شو المشكله، فممكن ندخل في اللاباروسكوبيك مثلا ابنديسايتس، ادهيجن، هذول الاشياء غالبا ما بيبين في الانفستيجيشن. تمام. السلايد اللي بعده what we can examine. اول شيء الابندكس، ثاني شيء الجول بلادر، ثالث الشغله الليفر، ممكن البنكرياس، small and large intestine اللي هو الكولون، السبلين، stomach, gastrectomy, pelvic and reproductive organ. يعني هذول الأشياء لازم تحفظوها. تمام. الآن نيجي على الجنرال ريكوايرمنت اللي بنحتاجها للعملية. أول شيء الأوبتيك سيستم. الأوبتيك سيستم بتتكون من الأوبتيك سيستم بتكون من تلسكوب اللي هو هذا الجزء، ثم كاميرا، ثم لايت سورس اند تي في مونيتور اللي هي الشاشه عباره عن LCD. تمام. التلسكوب هو الانفيسيف، والكاميرا بتكون خارجيه. اذا بتشوفوا فيها النقطتين الزرقاء والبيضاء، البيضاء بتكون للفوكس اللي هي وضوح الصوره، الزرقاء بتكون للزوم، نكبر او نقرب. نروح لسلايد 6. سلايد 6 في الانسفليتور، الديفايس that flow gases in constant pressure and unit. لو تشوفوا هان الجهاز المحطوط هان الرقم 30 هذا البرشر، غالبا اتوقع انه بيكون 14 بس يجي يسوي عمليه. اللي جنبه رقم 25 قديش الكميه اللي بتضخ لتر بالدقيقه. اللي جنبه الاصفار هذول اللي هي ايش كم الكميه اللي استخدمت في العمليه. تمام. فيها أنا برضو إشي ثاني بنستخدمه اللي هي الانسترومنتس، اللي هي المعدات اللي بنستخدمها في العملية، بندخلها من خلال جزء اسمه تروكر. التروكر بورتر for the instruments and for escape the gases from the organ within the body. تمام. هسه نيجي للبروسيجر. A ridge endoscopic laparoscopic is introduction throughout a portal into peritoneum cavity. This inflates with carbon dioxide to proceed pneumoperitoneum. Further, portals are inserted unable to instruments access and they are used to this dissection. الفكرة في الموضوع النيموبريتونيوم هو عبارة عن البريتونيوم لكن بننفخه في غازات. تمام. بندخل في تروكر اللي قبل شوي حكينا عنه اللي هو الرئيسي، ندخل منه تلسكوب، وممكن ندخل كمان أكثر من تروكرز، ندخل منهم الانسترومنت عشان نسوي الديسكشن. النيموبريتونيوم سلايد 8 في له طريقتين. الطريقة الأولى كلوز ميثود blind puncture using Verson needle. هاي الطريقة مع أنها سريعة إلى أنها بعض المخاطر، مثلا ممكن تصيب فاسكولار أو تصيب انستين، لكن هم بيستخدموا بتصيب الانستين. وطبعا بما أنها بلايند ما بيعرفوا أنهم وصلوا للبريتونيوم، عشان هيك بيستخدموا شيء بسموه سيرنج أو سلاين دروب تيست. بيسووا فلو للسلاين، إذا كان في ريزيستنس بيعرفوا أنه إيش لسه ما وصلوا للبريتونيوم. تمام. الطريقة الثانية اللي هي open method، خلينا نختصر فيها. open method بيسووا جرح يا بشكل طولي أو بشكل عرضي 1 سنتي، بعدين بيجيبوا 2 ريتراكتورز، يعني تخيلوهم زي خطافات بس إنه لهم أشكال كثيرة عشان يبين معهم الميد لاين فاشيا. بعدين بيسووا 2 سوتشرز على الجنبين عشان يخلوا بس فتحة 1 سنتي عشان يبين معهم الفاشيا. بعد هيك الدكتور بيحط إصبعه عشان يتأكد إنه وصل لوين، للبريتون. آخر إشي بدخل الهاسون تروكر وبثبته في الفاشية، ثم بيسوي انسفليتر يعني بنفخ النيموبريتون. تمام. الغازز اللي بنستخدمها في هاي العملية أول إشي CO2 والO2 والNO2 والإير الهيليوم نيتروجين. إحنا غالبا نستخدم CO2. السبب إنه better solubility in the blood, less risk for gas embolism، شيء valuable. بس له complication مثلا hypotension, local hypoxia and local acidosis not systemic. السبب إنه CO2 excreted by lung بتزيد increase الventilation. تمام. نيجي للادفانتج. الادفانتج decrease in the wound site من 1 ل 1.5 سنتي. Most trauma of opening procedure is inflicted because the surgeon must have a wound that larger enough to give. هذا السبب إنه بتخلي الأوبن سيرجري فتحتها أكبر. الإشي الثاني reduction in wound infection, de-adhesion, bleeding, herniation and nerve entrapment. طبعا هذا كله بسبب إنه سوينا فتحة أقل. decrease in wound pain بحكم إنه البين الوند أصغر بالحجم. improve mobility يعني فكرة open surgeries إلها complication أكثر، مثلا pneumoatachylisis, chest infection, paralytic ileus, deep venous thrombosis. decrease wound trauma السبب تاعها الميكانيكال and human retractors cause additional trauma. تمام. improve vision حكم إنه منفوخة البطن. decrease heat loss. الإشي اللي بيهمنا في هذا السلايد إنه بسبب الستمك تو ديكليننت سيروزا كفرينج بسبب لنا إيش less adhesions. تمام. هو سلايد 13. بعد هيك سلايد 14 اللي هو disadvantage release or remote vision and operating. الاندوسكوب بيبين لنا عالم آخر في الاناتوميكال الماركرز، يمكن الدكتور ما يعرفهم، فبيحتاج إنه يعني يتمرس عليهم، وممكن تعطيه miss and judgment في الدبث. الإشي الثاني depends in hand eye coordinate، بحكم إنه الأدوات أطول اللي بنستخدمهن فبتحتاج لمهارة أكبر تناسق بين العين وبين الإيد. بعد هيك سلايد 15 إن difficult with hematosis بس يصير في عنا arterial bleeding. الارتيال bleeding راح يسوي لنا reduction of image quality and light absorption. الشغلة الأخيرة اللي قبل الأخيرة لما نيجي نطلع الأعضاء الكبيرة راح تكون صعب في الاندوسكوبيك، لكن الادفانس لابروسكوبيك الآن بتقدر تطلع الأشياء الكبيرة. loss of tactile feeding back. طبعا هاي من أهم المهارات للجراحين، يعني الجراح ممكن لو يحط إيده على العضو بدون ما يشوفه يعرف. الإشي الأخير ليانس اون نيو تكنيكس، يعني لما نيجي نستخدم تقنية جديدة ممكن اللابروسكوبيك هذا كله يروح ونستخدم تقنية جديدة. هيك أنا خلصت الجزء بتاعي، إن شاء الله راح أكمل معك زميلي أسامة.
بسم الله الرحمن الرحيم. أنا زميلكم أسامة الفقيه، بدي أكمل الجزء المتبقي من محاضرة اليوم. هسه وصلنا للبريبريشن اوف ذا بيشنت. بنبلش أول إشي بالهيستوري، بنختار الجنرال أنستيزيا المناسب لحالة المريض، وبنسأل إذا في عنده كان بريفيوس كومبليكيشن أنستيزيا، وإذا بأخذ أني أنتي كواجولانت دراج منها الأسبرين والوارفرين، وبنسأله إذا هو سموكر ولا لا. لازم نحكي له يوقف السموكينج لأنها بتعمل واحدة من الشغلتين اللي هو الديلي الهيلينج افتر سيرجري، وثاني شغله بتزيد الريسك للانفكشن. ثاني شيء بنساله كمان اذا في اي بوتنشال كواجيليشن ديس اوردر صارت عند المريض، سواء كانت لو كلوت او هاي كلوت. اللو كلوت تؤدينا الى بليدنج، بتكون يا اما انهيرتد او بتكون ممكن اكواير، مثلا الفيتامين كي ديفيشنسي او الليفر ديزيز ومنها السيروسيس وثرومبوسايتوبينيا. والانهيرتد ممكن الهيموفيليا اي اور بي، والهاي كلوت ممكن تؤدي لثرومبس زي ما حكينا، فمنها الانهيرتد او الاكويرد. كمان الاكويرد ممكن يكون بريفيوس سيرجري، بريفيوس دي في تي اور بالمونري امبوليزم او نفروتيك سيندروم. وبنسال اذا كان عامل البيشنت اني بريفيوس ابدومينال اوبريشن او بيريتونايتس صاير عنده، لانه بنفكر في الادهيجن صارت في منطقه الابدومين، فبتصعب علينا عمليه اللاباروسكوبيك سيرجري. بالنسبه للاكزامينيشن، اللاباروسكوبيك سيرجري صحيح هو كويكر ريكفري وليس بوست اوبريتيف بين، ولكن كل ما طولت عمليه اللونجر اوبريشن طولت العمليه. النيومو بريتونيوم مع الهيد اب للبيشنت بتؤدي الى الاستيميوليشن للسمباثيك نيرفس سيستم، فبتؤدي الى الكاردياك اريثميا. فاي بيشنت له سسبتابيليتي فور اني ديفلوبمنت فنتريكولار اريثميا فما بنعمله اللاباروسكوبيك سيرجري. بنتاكد انه المريض ما عنده جوندس ولا ابدومينال سكارز ولا بالبل ماسز ولا تندرنس. الجوندس لانه زي ما حكينا فممكن يكون عنده obstruction، فما بيصير اي reabsorption of the vitamin K، فبتؤدي الى bleeding. والسكار معناته انه في عندك previous operation، بنفكر بالادهيجن. علاقه الاوبيزيتي مع اللاباروسكوبيك سيرجري، اذا كان البيشنت مودريت اوبيز فما بتاثر على اللاباروسكوبيك سيرجري، ولكن اذا كان ماسيف اوبيز فبتكون اصعب عمليه النيومو بريتونيوم اول شغله. ثاني شيء الانسترومنتيشن راح تكون شورتر. احنا المفروض الانسترومنت لما يدخل جوه في بطن المريض يكون لونج عشان يقدر يوصل للاورجن نقدر نطلعه بسهوله. وبالاضافه كمان بيكون عندنا ديفيكالتيز بنواجهها في الثن بيشنت، وخصوصا اذا كان معهم كايفوسيس. الكايفوسيس هو الاوتورد كيرفتشر اوف ثوراسيك سباين، فاللاباروسكوبيك سيرجري برضه بتكون فيهم عندهم اصعب. البري ميديكيشن هي من اختصاص طبيب التخدير، فزي ما حكينا بيسال مجموعه اسئله اذا كان في معاه كومبليكيشن من الانستيزيا قبل هالمره، شو عامل بريفيوس سيرجري، شو عنده ميديكال بروبلمز، باخذ انتي كواجولانت دراج الاسبرين وارفرين، ولازم يوقفهم قبل فتره من العمليه عشان ما يصير اي بليدنج. البروفيلاكسيس اجينست الثرومبو امبوليزم. في اللاباروسكوبيك سيرجري البيشنت هو بيصير عنده فينستيسيس لانه بيكون محطوط على البوزيشن ريفيرس ترندلنبرغ بوزيشن، يعني بيكون اتخذ مايل بشكل مش افقي، بيكون المريض بشكل اوبليك بنسميها، فبكون هو عرضه للدي في تي. وفي كمان شغلتين بتكون ريسك فاكتور، هي كمان اللينث اوف اوبريشن. كل ما طولت العمليه ممكن الدي في تي يكون فرصتها اكبر، وبالاضافه كل ما كان البيشنت اوبيز اكثر معناته فرصه الدي في تي اعلى. نعطي المريض سبكوتينيوس لو موليكولار ويت هيبرين، ونعطيه انتي ثرومبو امبوليك ستوكينج، وبالاضافه نعطيه نيوماتيك ليجنجز اللي هم عباره عن المشدات للاقدام عشان نمنع انه حصول اي دي في تي للمريض في الاوبريشن او بعد الاوبريشن. البيشنت اذا حكينا كان باخذ الوارفرين فبنحكي له انت لازم توقفه او تغيره للاي في هيبرين عشان ممكن احنا تعمل لك كواجوليشن ديفكت وتؤدي الى بليدنج. بنحط للمريض يورينري كاثيتر عشان نتاكد انه اليورينري بلادر امتي. لازم المريض يكون صايم. بنحط له نيزو جاستريك تيوب عشان نوصل الفلويد، نوصل النيوتريشن والميديكيشن للاستومك في حاله وهو كان في اللاباروسكوبيك سيرجري. نعمل انفورمد كونسنت، بنخلي المريض يوقع على ورقه ونشرح له فيها كل شيء عن النيتشر اوف سيرجري البروسيجر اول شغله. ثاني شيء شو الريسك. ثالث شغله بتكون عندك اذا في كومبليكيشن ولا لا. بعد السيرجري ايش راح يصير؟ بين على المريض اعراض مثلا الشولدر تب بين، نوزيا، ابدومينال بين، ممكن يصير فيه اي هيرنيا ممكن تصير. فالمريض لازم يكون عارف كل شيء. وبالنسبه للريسكس لازم تكون كوانتيفيتد، يعني تعدهم وتحسبهم تحكيهم للمريض كاملات، ويكون المريض فاهم كل شيء راح يصير معه وقديش راح تكون مده الاوبريشن وايش راح يصير بعد الاوبريشن. انه بعد اغلب المرضى بروحوا بعد اليوم بنفس اليوم او بعد بيوم من الاوبريشن، فبتحكي له انت لازم تجيب معك حدا اللي هو اللي يسوق السياره، انت ممنوع تسوق السياره على الاقل لمده 24 ساعه. هسه ممكن تصير عندنا كومبليكيشن واحنا في اللاباروسكوبيك سيرجري، منها الانترا اوبريتيف بيرفوريشن اوف جول بلادر. احنا بنعرف انه البايل نوت ستيرايل، فبكون فيه بكتيريا حتى لو ما كانت فيه كوليسيستايتس، ما في اي اعراض مثلا الكوليسيستايتس. اي بيرفوريشن بيصير للجول بلادر لازم يتسكر في الاندولوب او الاندوكليبس. الاندوكليبس تيجي زي ملاقط طبيه بيكون على الاطراف زي الحدايد، فبتسكر فيها الجول بلادر. والاندولوب زي الخيطان الطبيه عشان تمنع اي كونتامينيشن وتمنع البيريتونايتس انها تصير. البليدنج، اي البيشنت اذا بيعاني من اي ريسك اوف بليدنج فبكون هو كونترا انديكيشن تو لاباروسكوبيك سيرجري. حكينا منهم اللي هو الليفر ديزيز ومنها السيروسز، الانفلاماتوري كونديشن، او البيشنت اون انتي كواجولانت ثيرابي، او الكواجيليشن ديفكت عنده اي مشاكل في الكواجيليشن سيستم تؤدي لبليدنج، او العكس ممكن تؤدي لثرومبس. البيشنت بعد السيرجري رح يبين في عده شغلات منها النوزيا. اكثر من نص المرضى رح يبينوا في نوزيا، والسبب هو الانتي ايميتيك ثيرابي اللي بنعطى للبيشنت، فبتكون عادي وبسيط. او الشولدر تبين. الشولدر تبين مشكله مش في الشولدر بيكون هو نورمال، ولكن انه الديافرام بيكون فيه البين منه وراديت تو ذا الشولدر تب بين، تعطيه انالجيسيا وريليفد. ابدومينال بين، اذا زاد الابدومينال بين افتر 2 to 3 داي فمعناته انا في عندي انفكشن، لازم نعطيه ايش؟ الانتي بايوتيك. وممكن تصير لوكالايزد بين معناته في هيرنيا، والهيرنيا معناته انه انا سيرجيكال كات doesn't close properly. نعطي البيشنت انالجيسيا ديكلوفينيك عشان تشيل البين. والاوبيات ما بتنعطى الا في حالات السيفير بين لانها بتعمل نوزيا. الاوروغاستريك تيوب واليورينري كاثيتر تنشال قبل ما المريض يرجع الى حاله الكونشوس. والاورال فلويد بنعطى للبيشنت الاورال فلويد عادي بعد ما يصحى بعد اللاباروسكوبيك سيرجري، ولكن نتاكد انه ما في اي إلياس. والاورال فيدنج بتقدر تعطيه هو لايت ميلز من بعد 4 إلى 6 ساعات من العمليه، ما يزيد حجم الميلز. واخر شيء هون السلايد الاخير بحكي لك انه اللاباروسكوبيك سيرجري هو مينيمال انفيزيف، ولكن صار في تطور وصلنا للليس انفيزيف اسمه سنجل انسيشن لاباروسكوبيك سيرجري. بدل ما نعمل اكثر من بورتس ونعمل العمليه فيها، فاحنا بنحتاج لبورت واحده اللي هو بتكون على منطقه الامبلايكس، بتكون هي ناتشرال سكار، ما في يعني سكارلس بدون اي سكار، وبورت واحده يعني سيجن واحده بندخل منها كل اللاباروسكوب وبندخل فيها الانسترومنت. بتكون ليس بين وليس ريسك اوف بليدنج وليس ريسك كمان للهيرنيا، وبتكون هي من كل النواحي احسن من اللاباروسكوبيك الموجود حاليا، ولكنها لساتها difficult and steep learning ولا زالت في الراندومايزد ترايلز اللي هو التجارب العشوائيه، فما انتشرت انترناشونالي. وهيك بنكون وصلنا لاخر محاضره اليوم اللاباروسكوبيك سيرجري. اذا في اي سؤال حدا بده يسال يتفضل. ما في اي سؤال؟ طيب يعطيكم العافيه.
شوف الجروب اللي بعديه.
السلام عليكم، يعطيكم العافية. الصوت واضح من عندكم؟
نعم واضح، تفضل.
تمام. أنا زميلتكم لين أو سرحان، واليوم إن شاء الله أنا ونور راح نحكي عن approach to patients with renal pain or bleeding rectum. تمام. أول شيء ال GI bleeding is divided into upper and lower GI bleeding. Lower GI bleeding is any source of bleeding that is distal to the ligament of trades. زي ما شايفين عنا بالصورة عنا ligament of trades suspend عنا distal duodenum، وبالتالي أي bleeding بعد distal duodenum to the anus يعتبر lower GI bleeding. تمام. هلا lower GI bleeding is represented as bright red blood rectum بنسميه hematochezia, and this is very important to differentiate it from melena, which is passage of black tire stool that indicate upper GI bleeding. But this is not the case لأنه ممكن يكون عندنا hematochezia بالupper GI bleeding. yes ممكن في حالات 15 تقريبا 15% أفرين acute hematochezia بيكون سبب لها massive upper GI brisk bleeding. هلا الكلاسيفيكيشن ممكن نعمل كلاسيفيكيشن according إنه to acute or chronic. الأكيوت غالبا بيكون عندنا instability of vital signs، وبالتالي the first step of management إنه نتأكد من vital signs ونعمل stabilization للبيشنت إذا كان presented with acute bleeding. إذا كان chronic غالبا بيكون عندنا intermittent or loss of slow loss of blood. غالبا بيكون عندنا chronic disease like inflammatory bowel disease or even cancer. هلا رح نحكي عن الموست common causes of hematochezia. أنا رح أتطرق لموضوع الكولين causes بشكل عام، وزميلتنا إن شاء الله نور رح تحكي عن anal disorder. أول cause عنا diverticulosis. Diverticulosis is most common cause of massive lower GI bleeding. غالبا بيعمل non-painful bleeding إلا إذا صار عنا inflammation. إذا صار عنا inflammation بنسميه diverticulitis. بيكون عنا painful bleeding. هلا diverticulum زي ما شايفين عنا هون بالصورة بالcolonoscopy is blind pouch، يعني إذا حطيت فيه دخلت فيه أي شيء it will be empty. غالبا بيكون عنا asymptomatic، and إذا صار عنا complication presented with hematochezia and or diverticulitis. هلا diverticulitis بسموها left sided appendicitis. ليش؟ لأنه الclinical picture إلها as the same as appendicitis presented with fever with leukocytosis and abdominal pain. بس اللهم بدل ما يكون عنا بالرايت بيكون left lower quadrant pain and of course طبعا presented with hematochezia. هلا رح نروح على angiodysplasia. تمام زي ما شايفين عنا هون بصورة الكولونوسكوبي it's apparent blood vessels in the GI tract. and غالبا كمان نفس الشيء هي بتكون عنا asymptomatic but may bleed, and also it's a common cause of hematochezia slow GI bleeding. الإسكيميك كولايتس عليها. هلا الإسكيميك كولايتس بيكون الكوزز اللي إلها under perfusion of large intestine، فغالبا بتكون patient who are critically ill in the setting of hypertension condition زي الشوك زي الهemorrhage any cause of hypertension. غالبا إن الإسكيميا بتكون بالwatershed area بسموها هيك لأنها have limited collateral زي السبلينيك flexure and rectosigmoid junction. الdiagnosis غالبا بيكون clinically، يعني واحد مريض in the setting of hypertension عنده abdominal pain ممكن يكون عنده ischemic colitis. الكولونوسكوبي غالبا إنه هو نادرا ما ينعمل، بس إذا نعمل ممكن زي ما مبين بالصورة في عنا multiple pale area this indicate ischemia. تمام. هلا inflammatory bowel disease هما immune mediated disease، هما chronic وبالتالي they are represented طبعا both Crohn's disease and ulcerative colitis. They are represented with abdominal pain with hematochezia and bloody diarrhea that are chronic. هلا المقارنة بيناتهم إن ulcerative colitis أول شيء من اسمه as name indicated ulcerative في عنا ulcers. colitis isn't just only specific to the colon to the larger intestine. بيكون عنا فقط عنا mucosal inflammation. والكرون ديزيز، بينما الكرون ديزيز ممكن يكون بأي بارت أنا في GI tract، يعني is not only limited to the colon. غالبا بيكون the most common site إلى الإليوم. زي ما بنعرف إنه الإليوم هو the site of renal absorption of vitamin B12 is the site of renal absorption fivefold. عشان هيك most common بيكون عندهم malabsorption، بيكون عندهم vitamin B12 deficiency، بيكون عندهم staturia secretory diarrhea، يعني is not only زي ما مكتوب بالسلايد إنه bloody diarrhea. وطبعا هي inflammation بيكون إنه include إنه all the layer of the GI tract، عشان هيك بيسموه transmural inflammation. زي ما شايفين هون بالكولونسكوبي بالصورة في عنا multiple and ulcers. This indicate ulcerative colitis إذا بقارنوها بالصورة اللي فوقيها اللي هي النورمال one. هلا طبعا ممكن نعمل بالulcerative colitis والcrohn disease colectomy. ليش؟ لأنه have high risk to develop renal cancer. عشان هيك مهم جدا إذا واحد عنده inflammatory bowel disease إنه دائما يعملوا إيش؟ يعملوا screening by colonoscopy عشان نتأكد إنه ما فيش كانسر. هلا البوليبس هي benign outgrowth of tissue in the colon. most common بتكون إنها benign could be precancerous. إذا كانت precancerous بيعملوها لها removal. هي غالبا asthmatic، ولكن أنا large polyps إنها can be presented with bleeding and this bleeding is not visible من السم. عشان هيك is very important as a screening test for colon cancer اللي هو إيش اسمه occult blood testing. ليش؟ لأنه إذا طلعنا positive إن patient معاه polyps هذا indicate إنه شو عنده؟ indicate عنده large polyps bleeding. بالتالي this indicate إنه عنده colon cancer. ليش؟ لأن polyps إنه كل ما كان إن الحجم أكبر كل ما كان الريسك إنه to develop colon cancer إنه أكثر. third cancer and is the third most deadly cancer. غالبا إيش كمان نفس الشيء غالبا asymptomatic عشان بيعملوا لهم screening risky group يعني في high risk people. right sided and colon cancer غالبا tend to be large in size and tend to bleed slowly. فغالبا with iron deficiency anemia and with weight loss. عشان كده أجل مريض old age or even postmenopausal female with iron deficiency anemia you should think of colon cancer. left sided tumor غالبا presented with hematopoiesis. هلا red flags of colon cancer مهم جدا بالهيستوري نسأل عن الريد فلاكس عشان نستبعد الكولون كانسر لأنه very serious. منها هاي الأشياء ممكن إذا كان عنده هنا chronic constipation, chronic diarrhea أكثر من 6 أسابيع، إذا كان عنده chronic rectal bleeding or even chronic ocular bleeding، إذا كان عنده weight loss، إذا كان عنده loss of appetite، أيضا إذا كان في عنده history of malignancy or even inflammatory bowel disease as I said. هلا بدنا نحكي عن الابروتش to acute lower GI bleeding. هلا إذا إجا على الإمرجنسي حدا عنده هنا acute hematochezia. The first step you should do إنك تعمل إيش؟ تتأكد is the patient hemodynamically stable or not. يعني أول شيء أول step بدك تتأكد من vital signs، تتأكد من البلس اللي هي blood pressure، من البلس. ليش؟ عشان ما يصيرش عنده إيش؟ hypovolemic shock. بما إنه acute bleeding ممكن يدخل hypovolemic shock، ممكن يصير عنده death. أول step بدها تكون عن stabilization. عشان هيك you should very quickly immediately establish an IV access إذا كان طبعا an unstable patient. So you can administer an IV fluid or an blood product. فغالبا إذا أعطيت an IV fluid بصير البيشنت stable. ممكن بعض الحالات إنه يحتاج blood transfusion platelet يعني حسب الكيس. هلا الانشال عندنا evaluation أكيد طبعا أنا include history physical يعني examination laboratory test. طبعا أنا بتكون تقريبا كله يعني بيكون مع بعض. هلا الهيستوري في حالة إن الأكيوت bleeding مهم جدا الواحد يسأل عن شو عن prior episodes في GI bleeding. The past medical history is very important to identify potential bleeding sources. أيضا medication use very important خصوصا إن agents that are associated with the bleeding or may impair coagulation like an NSAID like an anticoagulant antiplatelet agent. أيضا ممكن نسأل عن symptoms that may suggest a specific cause. For example إذا كان معاه painless hematochezia ممكن indicate عنده diverticulosis. إذا كان عنده أي شيء من الريد اللي flags اللي already حكيتهم بالسلايد قبل ممكن يكون عنده colon cancer. إذا كان عنده abdominal pain may indicate an inflammation. إذا may indicate colitis. طبعا الهيستوري كامل family history with the social history. في عنا الصورة هاي this is Rina Fab اللي هو familial adenomatosis polyposis. This is an autosomal dominant disease. بكون هنا في multiple polyps. زي ما حكيت بالسلايد قبل بالبوليبس إنه كل ما كان السايز of polyps أكبر كل ما كان الريسك of progression to colon cancer أكثر، وبالتالي نفس الشيء العدد، كل ما كان النمبر أكثر كل ما كان ال progression to cancer نفس الشيء أكبر. وغالبا صعب without treatment 100% progress to cancer يعني أكيد، فغالبا بيعملوا لهم colectomy surgery عشان يمنعوا ال progression. هاي physical examination. الفيتال ساينز اللي حكينا of course بنتأكد منهم عشان نتأكد إنه ما يدخل بهايبروليميك شوك. بعدين الفيزيكال examination نضلنا نعمل assessment في vital signs. ممكن نعمل stool sample عشان نتأكد إذا هي هيماتوكيزيا يعني أو ممكن تكون أناميلينا. اللابراتوري تيست إن CBC عشان نتأكد من الهوماتوكريت من الهوموجلوبين. ممكن platelet ممكن coagulation factor يعني. هلا type is very important عشان إذا احتاج blood transfusion يعني so it's very important to know type of blood. هلا ممكن إنه نعمل upper endoscopy ممكن. ليش؟ لأنه as I said إنه 15% فينا acute hematochezia بيكون الكوز إلها upper massive GI bleeding. مثلا ممكن أنا brisk peptic and ulcer bleeding أيا كان الكوز إنه ممكن كان be presented إنه with acute hematochezia. هلا بعد ما تأكدنا من البيشنت وخلص صار عندنا stabilization والمريض وضعه تمام، أول خطوة ممكن نعملها اللي هي الكولونوسكوبي عشان نشوف السورس of renal bleeding. إذا أنا the best choice of diagnosis is renal colonoscopy because it can precisely localize the bleeding. Also you can by it collect an specimen, you can by it treat the bleeding. وغالبا بنعمل بالstable patient. ليش؟ لأنه بيحتاج full preparation وبيحتاج sedation زي هيك، فغالبا بنعمله بالstable patient. بعد الاندوسكوبي ممكن أنا تشفيت البليدنج إذا كان small bleeding by colonoscopy، إذا كان breast bleeding ممكن بالانجيوغرافي. وبعدين إذا عرفت الكوزز خلاص تعمل management and according to the cause of renal bleeding. وفي عنا كمان في طبعا أنا هاي كيس ممكن تختبروا حالكم فيها. وأنا هيك بكون خلصت أنا الابروتش to acute bleeding والrectal bleeding. إن شاء الله نور زميلتنا نور راح تكمل معكم مع الanal disorder. يعطيكم العافية.
السلام عليكم. أنا نور عودة. إن شاء الله رح أكمل معكم من anal pain. First of all, you need to know that anal pain mainly come with defecation. So we have four main causes of pain. They are anal abscess, anal fistula, and anal fissure, and complicated hemorrhoid. And not all hemorrhoid will cause pain. First of all, we will talk about hemorrhoid. We divide hemorrhoid to internal hemorrhoid and external hemorrhoid. Internal hemorrhoid is above the dentate line, while external hemorrhoid is below the dentate line. Above the dentate line, it's leg sensory innervation, which is painless. So internal hemorrhoid is painless unless there is a prolapse. External hemorrhoid, because it's under dentate line, is supplied by the cutaneous nerve, so it's painful. We have another type. There is a thrombosed hemorrhoid, which is blood clots in the external hemorrhoid, which will form a clot, which is cause a severe pain. Internal hemorrhoid we classified into four categories. First one, which is no prolapse, only minimum or asymptomatic bleeding. The second grade, which is prolapse with staining or defecation with the spontaneous reduction. While grade 3, there is prolapse with no staining and need manual reduction. While grade 4, there is a chronic prolapse. Even if there is a reduction, it will relapse again. And it needs surgical intervention. Okay, external hemorrhoid, it's itching, paining, and there's anal mass and bleeding. Internal hemorrhoid, it's painless unless there's a prolapse. What are investigation? We need to know that hemorrhoid is diagnosed by visual examination. So we will perform a physical examination and rectal examination. We need to know that hemorrhoid is not palpable unless there is a thrombose and fibrous. And internal hemorrhoid will be diagnosed by proctoscopy. And we can do a sigmoidoscopy and the colonoscopy if we want to know if there is another pathogen. Exclude. And CBC for anemia. There's a long standing chronic hemorrhoid. What are treatment? We can laxatives, high fiber diet, and hygiene and topical steroid and sits back. These two we used for external hemorrhoid and stage 1 and stage 2 internal hemorrhoid. Stage 1, stage 3 rubber band ligation, and stage 4 internal hemorrhoid surgical resection. Anal fissure, it's a tear in anal epithelium which occurs percent in the posterior wall of the penis. We divide it into acute and chronic anal fissure. Acute, which is associated with the spasm of the anal sphincter. It has a prior streak of blood with passage of the stool, and you need to know that anal fissure is always associated with defecation. Chronic, it's characteristic by a triad. It is a hypertrophied papillae and also a central pal and anal fissure. A central pal, it is distal to the anal fissure, which is a thickness of the mucosa or the skin, so it will confuse with a small hemorrhoid. Anal fissure, it's the most common cause of preanal pain, and it includes bleeding and constipation, and also pruritus and hypertrophic papillae. And semitile papillae, which occur in the chronic, also hypertrophied papillae, it's in a chronic fissure. Clinical examination of the fissure is only inspection because it's very painful. So distal rectal examination, it's not performed in anal fissure. Treatment, 90% of anal fissure will heal without medical, it will heal with medical treatment. Sanitized bath, stool softening, high fiber diet, and excellent anal hygiene, topical nifedine, and Botox. Only in a refractory chronic fissure, we need a surgical intervention. Anorectal abscess, it's characteristic by rectal pain and range of the pus, fever, and renal mass. It diagnosed by physical examination and distal rectal examination. Anorectal abscess, as any abscess, it's needed drainage and sanitized bath and anal hygiene and stool softening. We need to know that after a surgery, no need to give all patient IV antibiotic. Only we can give immunosuppressant people, diabetes, heart valve abnormality, and cellulitis. We need to know also that even if we treat abscess, there is a percentage for occurrence of fistula. Anal fistula, it is a tract, abnormal tract formed between the rectum and the anal cavity. It arises mainly from negligent pre-anal abscess. Anal fissure, in history taking, there will be a previous pre-anal abscess. There will be a pruritus and pain with defecation in case of abscess built up, and tenderness during rectal examination. What are the investigations need? First, physical examination, inspection for any opening in the anal area, and most fistula required no investigation other than a formal examination under anesthesia. We can do proctoscopy and colonoscopy if we want to exclude any pathological condition like Crohn disease, and fistulogram to see the tract. Anal fissure management, it depends on the patient stability and the level of the fistula, and if there is abscess, we need to drainage the abscess and fistulotomy, which is the most effective procedure. What are the approach to the patient with anal pain? First of all, history. If someone comes with pain, we need to give a painkiller. Then we will start with history taking. If he said that it's pain with defecation, so it's mainly a fissure. If he said that his pain started gradual and for several, it may be a thrombus, external hemorrhoid, and anal abscess. What is characteristic of pain? Because fissure is very painful, it's characteristic by a sharp knife-like pain, especially with bowel movement. While in hemorrhoid and anal fissure, it will be a dull, constant pain with no association with bowel movement. There's also about the tender limb or swallowing. We need to know that large limb is hemorrhoid and tender swallowing is anal rectal abscess. Examination during inspection. If we see a tender blue lamp around the anus, it's more likely to be a thrombus, external hemorrhoid. Tender red indwelling swallowing around the anus is interrectal abscess, or small tag lamp, it will be anal fissure. Treatment, first of all, relieving of the pain, then to treat the underlying condition. These are the investigation can we use for bleeding, perectum and anal pain, colonoscopy, sigmoidoscopy, and perineum enemy, and CT scan, ultrasound, proctoscopy, and rectal examination. Colonoscopy, advantage of colonoscopy is we can see the lesion. While disadvantages, we need to do a bowel preparation before doing the procedure. This is the sigmoidoscopy. Perineum enemy, it's a fluid perineum liquid that inserted in the enemy into the rectum, and we see by the X-ray. Proctoscopy is mainly used for hemorrhoid. And rectal examination. First of all, we know that we need to introduce ourselves, take information of the patient, take constant hand hygiene. Then we can do the procedure by inserting, wearing glove, lubrication, then inserting 2 fingers, and we need to when inserting the finger, we need to rotate our finger 360 degrees to see if there is any mass. And this, we leave only one case, so if you want to read it and solve it, and هيك بنكون إحنا خلصنا السيمينار تبعنا. وشكرا. إذا عندكم أي سؤال تفضلوا.
يعطيكم العافية طلاب. تفضل، في حد عنده استفسارات؟
دكتور أنا عندي.
تفضلي، علي صوتك بعد إذنك. أنا اعذروني الإنترنت فصل ورد رجع.
مسموع صوتي؟
مسموع الآن، تفضلي.
في بمحاضرة الجال بدر حكيت عن دواء اسمه أورثوديوكسيريكوليك أسيد أظني.
نعم.
أنا ما فهمت، أنت حكيت هو كان زمان بيسبب الجال ستونز، هلا بيستخدمه
هو كان يستخدم لإزالة الجول ستون لإفكاسية تعيته قليلة. المرضى اللي ما بينفع معهم عمليات ممكن نستخدمه يوردوكسيكوليك أسيد، لكن هو مش بيسبب، هو بزيل الحصوات بتقلل من الانسيدنس للفورميشن.
تمام.
نعم
شكرا.
في حد عنده اي استفسار؟ يعطيكم الف عافيه.